percent, that is 1,000 million, they have remaining 10% resources. We have 2.4% world land, which inhabitates 16% world population. 72% is rural, that is 5,50,000 villages. And we have this triangle of rural population is covered by a current health services, which is a reverse triangle. Now, as a result of it, lots of area of population, they remain uncovered with health services, while lots of area of urban health services, that is yellow triangle coming outside, they are underutilized. Now, let's look at the patient load of the nation. 30 million new children are born per year. So it's a natural share of congenital problem. 50 to 60% living on less than $1 a day. So nutritional problems. Infection multiplies because of pocket of undernutrition and bad hygiene. So there is plenty of infection. And 7% population is over 65 years of age, that is 84 million. So we have a significant amount of degenerative work is to be done. And more important, that is that we are living in a trauma epidemic. This was injury pyramid of 2005. In 9 years' time, I'm sure these figures must have increased. But in this 2005, we had 8,50,000 deaths because of injury. That means 17 million were those who were seriously injured, they were to be looked after, and 42.5 million were those who had sustained minor injuries in that very year. Now in 2005, I'm sure this figure is going to be a little more. And it is not simple trauma because we are not getting it right for the first time. We get neck femur which is 3 months old, neck femur which is 6 months old, a gap non-union femur which is 10 years child is walking, is living with this for 9 months, for a long time. And so even the surgically induced complication. So practically it is a super epidemic of neglected trauma. And since we are not getting it right for the first time, we get lots of neglected and late presentation. We get spinal tuberculosis for the first time, reaching to the major center with this kind of such a severe kyphotic deformity. Or you could see that lumbar spine with almost 50-degree kyphotic deformity with 2 vertebrae have totally disappeared. Now, so it means that we see the true natural history of disease. But then you have to treat them, you have to find the solution of these clinical problems once they come to you. Now, this is what was the patient load, but what are the barriers to delivery of orthopedic care? They are inadequate resources, not in terms of finances, but in terms of health facilities, a lack of trained health provider, difficulties in accessing healthcare services due to geographic constraint, and educational and training issues. Let's look one by one. Since inadequate infrastructure, what does that mean? Is that there is no available area-specific hospital or clinic. That is not assured. They are there, but not being assured that each part of the country, each area has an area-specific hospital or clinic. There are no evacuation plan for the disaster situation in different areas. So there is no definite line of action in case of happening. So it is not simply missing golden hour, but missing a golden day. And most of these are preventable death and disability. And even if hospital is located, there is a skeleton staff of doctors, nurses and paramedics in periphery, which is that what I was talking about, the triangle of the rural population, which is uncovered by the health services. And equipment, drugs are insufficient quantity and quality. So there is an enormous unmet need of surgical services. There is a mismatch on the need of facility. You need some kind of facility at some places, but then that available facility is not good enough and that very geographic location in comparison to some places where that facility is in plenty. Now, overall healthcare sector is divided into two: public sector, private sector, both are running parallel. Public sector has a tremendous intellectual capacity. They lack state-of-art infrastructure. They have a very heavy patient load. Any hospital, general OPD would have 500 outpatients with 250 new patients coming on that very day. 60 to 90 emergency patients attending every hospital's emergency. And with such a huge load, a poor documentation, poor record keeping, poor follow-up, and migrating populations. So the experience is not added as a research experience, or is not being added as an evidence on which we can base the improvement in the services. And there is no hospital-specific clinical work. While private sector is a corporate hospital which has a state-of-art technology, limited clinical work in volume and spectrum of disease, and they are not generalists but subspecialty expert. And you can get best of the treatment available on the land in these corporate hospitals. Now, best services are those where quantum of workload matches the infrastructure. And since burden of musculoskeletal disease and of trauma in total and specific geographical area is not known, hence it is generally not matched with the infrastructure available. Well, there are certain geographic constraints. Well, though health facilities are located, may not be located, but then even if it is located, there is a availability of mean of transport is not assured. How the patient will be moved from the site or from the home to the nearby facilities, and this patient has to, a family has to take them, and that adds indirect cost onto the household. Pre-hospital care is not uniformly there, and there is a huge information gap in the local area where people do not know where to transport if one such eventuality occurs. Now, there are certain educational and training issues. Well, in modern medicine, practices used to be guided by the West, because whatever they advocated, it was followed in principle and practiced successfully, and that has worked successfully till last 60 years ago, because there was not much disease dissimilarity in the West and in the underdeveloped area. But now there is a huge dissimilarity. The gap about the treatment needs between developed nations and unequal world, that is developing world, is widening. And hence, according to one of the study from Pakistan, only 30% of the current curriculum is used for orthopedic care in developing countries. Well, we all know that Western training is super specialty based. So there is a confused education model in developing countries. What is the core competence and how they have been attained is not sure, and not a core education being delivered uniformly. And that is why I believe that orthopedic services and training are at a crossroads in developing countries. Well, I think this all was problem. Then what is the solution? Solution will come from a holistic approach, that is a simultaneous approach. Opening of one clinic or one hospital or one medical college or one AIMS-like institution alone doesn't work, because these are all populist steps. You can get some votes, but it cannot give minimum standard of care to each one citizen. We have to bring a change in attitude, everyone's attitude, and not government alone. It may be clinician, association, NGOs, government, and that is what is identifying the disease burden at a national and regional level, integrating infrastructure with population density, developing need-based curriculum and training models, ensuring core competence is attained by our trainees to treat patients in available medium, and they have to cultivate research temper to conduct need-based research, because they have to provide scientific evidence to treat clinical problems unique to our land. Ensuring maximum utilization of available infrastructure by doing a time audit, networking of peripheral clinic centers with specialized facilities, and developing evacuation and patient care protocol for each level of center. Well, looking at disease burden, whether it is national or regional, who will do? Will the individual doctor will do, or association will do? Well, there are two ways of doing it. Either you do a continuous screening or survey of the whole population, that's very costly, but however, this can simply be done by pooling the data in a geographical area of the clinics and the hospital base, and that will give us a rough idea of a disease burden. Well, coming to curriculum and training, we need to impart a focused training to treat prevalent clinical problem in available resources. It has to be a competency-based training, and uniform delivery of core education is a must. And that, because I believe teaching and learning, they are integral component of sound patient care. Say for example, essential service provider in periphery must be well versed with close treatment by manipulation, traction, care of open fracture, external fixation technique, skin cover. There is no point in knowing a complex reconstruction when a person is a essential service provider, when he has to differentiate between a benign and malignant lesion clinically and to decide line of action at first instance, and which he is not competent enough to do. And he has to be well versed with the rational treatment of fracture. What do I mean by rational treatment? Choosing right option of treatment in given available infrastructure so that complication can be minimized. Training for the healthcare worker, nurses, paramedics, OT technicians. Well, how many India need? I think it is more than 500,000 we require. So we need to create training facilities for them. We need to cultivate research chambers to conduct a need-based research so that one can provide a scientific evidence to treat clinical problems unique to our land. The research in developing countries and country like India is not a luxury, is not a CV building, it is a necessity because we have to give a solution to our clinical problems which are unique to our land, and that is why we have to cultivate research attitude and a passion for learning. Well, time audit of available infrastructure has to be done. Well, I was just writing this editorial on Bone and Joint Day for the India. I just looked at my own hospital, that how efficiently our operating system or our operation theatre is working. And I found that it is working at 66% or 70% capacity. It means one single hospital, if it works at 90% potential, then can do 5,000 operations per year without spending a single penny. Now put that figure to the whole city of Delhi. I'm sure almost 1 lakh operations can be done without spending a single penny if we just time audit the infrastructure available. And put this figure to the national level. So how much, at one end we have an unmet need of surgical services, at other end we are wasting lots of infrastructure just because of some small silly things. Well, I just did this networking of a peripheral clinic center with the specialized facilities for Tamil Nadu because I just delivered one similar lecture in Tamil Nadu. I think if you look at the Google map, you will get map for every region. Roads in Tamil Nadu, temples in Tamil Nadu, tourist, river, where is a health infrastructure map? It doesn't exist. We need to network the peripheral clinic centers with a specialized facility. We have primary health center at every small tehsil. We have a district health center at every district. We have a huge tertiary care center in almost a difference of 100 kilometers, and you will find one excellent tertiary care center. Why not link all of them? Grade the facilities. Few PHCs, let them provide essential services under one district center. Let them provide secondary services, and few district centers under one tertiary care, and that's how one can cover the whole state and whole nation. And this can simply be done by having some telemedicine contact with the tertiary care center, with the periphery. And for a country where IT, it's the IT hub of the world. It doesn't require big money. It just requires a will and a planning to do it. We need to develop evacuation protocol for disaster, patient protocol for each level of center, inform masses about the help available nearby. You go to the flight, you are announced that from your seat, the next exit door is available so near. You just look at your exit door. In your hotel, you know where is the exit door when there is in case of fire. So why not the whole population is educated where they can get the help and how and where to transport. Treat them efficiently at first instance. If treated well, it reduces disability adjusted life year. Lots of complications are averted, disability prevented, and not only that, many of them may not require care from tertiary care, and that further reduces disability adjusted life year, and that's what is the implication on a financial burden. Now question comes, who to do what? Is the government, state or central, or association, or individual orthopedic surgeon? Well, I personally believe, let us first do our bit. If we do our bit, we stand and we make it a little example, then I am sure a lot of government agency has to follow in. And that is why I have appealed to the whole country population of orthopedic surgeons that let us take 2014 as a year for change, at least to start a change in thought process, in attitude, in perception and outlook, because change in mind today will bring change in lives of so many. Well, our Indian Orthopaedics is in 59 years of its existence. It has achieved its first objective in cultivating brotherhood, sense of fraternity, learn to tolerate opinion difference, and provided a forum to interact art and science of orthopedics. But that is not enough. We have to move to the near area, contribute to the improving bone health of the masses by participating in health-related policy decisions, by providing minimum standard of care to one and all, and participating in orthopedic education issues. We have to ensure that every Indian attain peak bone mass. We have to sensitize, educate people that what is a peak bone mass and how can they do it. It doesn't require big money, it just requires some approach. Iron tablet given throughout the country just to increase the hemoglobin of pregnant women. We can certainly improve their vitamin D level and all their deficiency state. So we need to ensure our population attain peak bone mass. We at the moment are totally dealing with the masses. Common man thinks that we flourish on their miseries and misfortune. They should feel that we are concerned with their health status. And IOA has now started working on some of these initiatives. Well, on trauma recently, with the efforts of Rajashekharan, we got a good judgment on PIL in Supreme Court. Now policymakers cannot sleep. They have to submit the project, the planning in a few months' time to the Supreme Court. Let's work further to see the action plan by government is in place in reality. Well, the theme for this year is cultivate research and attitude and learning a passion. We have started working on uniform delivery of core education. We are using televised network of Doordarshan, which is free to all, and we are getting almost 10 hours education on this network where core education is being delivered. We have started working protocols and instruction course lecture, which is evidence-based from this year, and IGO as a platform to publish as evidence for locally conducted research. Well, now we are thinking about to create an Academy of Indian Orthopaedic Surgeons. It's a group within the IOA who will continuously brainstorm, who will just work on education issues only, and they will continually brainstorm to reform orthopedic education and oversee implementation. I think, friends, because our broader objective is to provide optimum standard of care to each and everyone. I think it's a very long drawn task, and recently we have improved our interaction with the public. On 29th July to 4th August, it's a bone and joint week in India, and we have given a slogan, save the bones and save the joints, where every district, every city, every state capital, everywhere the program will be held, and we are trying to reach to the common men with the common knowledge, because we want to alleviate misgiving among common men and guide them preventive tips to be born healthy. Friends, together only we can minimize, if not eliminate, the pain and disability from India and the world. And I think I appeal to even IOS UK community, because most of you are IOA member, and you are the best person who have seen that, who have worked there, who have been trained there, and now you see the other side of the coin also. So some method has to be adopted where we can provide an optimum care to one and all, if not the best of the care to everyone. And that's a Herculean, that is the distant objective, but at least try to give us and give your hand and join us in providing an optimum and minimum standard of care to one and all. Thanks very much indeed for patiently.